I don't want to be overly generalizing about it, but we appear, at least for now, to have failed with BMP. It's highly expensive, seems to give rise to relatively poor bone, and certainly hasn't captured the commercial market in quite the same way that the potential captured our minds 20 years ago, 10 years ago. So do you see the future in individualized technologies like that, or stem cell technologies, or do you think it's Rio's idea, out of a bottle, or do you think that it is already individualized by using the patient's own bone? Leading question.
Yes, thank you. You know, stem cells are, of course, very interesting. And if you see what the science is reaching with stem cells research in the last 10 years is unbelievable. But there is a lot of things, we have still a lot of questions because the body is not always reacting how we are expecting. So you see on one side perhaps a positive reaction, but perhaps on the other side you are activating negative reaction. And we don't know too much. You know, our knowledge today, I think it's so small from the real what really exists. And I don't think that we are going to have a revolution in a short time with the stem cells technology. Although I think it's going to take much more time, similar as with the BMPs. I remember as we start in the 80s with the BMP, the physiology professor came to me and said, we have something, a revolution. You can put it in big cysts, you can put it in tumor patient where you remove and you will have bone. And we will believe this, and we know today that it's not the truth because we don't have only one BMP. We have more than 30 BMPs, we know until now, and what we are using is one or two. And we don't know really all the reaction and the reaction of the body. So
I know, Lyndon, you pay great, and rightly so, great weight to host response. You've done an immense amount of work in the bone biology field. Do you share those views?
Well, we've had the experience of treating 122 of 144 consecutive patients with BMP2 as a bone graft material. And our experience yet remains to be published on the volumetric level, but we can tell you that the host is a remarkable mediator of the BMP response. I will also tell you my disappointment with BMP is people don't use it as a biological tool, they use it as a bone graft material. And I think we all make a mistake in thinking that BMP is a bone graft material. BMP is a morphogen and is targeting our cells, and therefore we need to develop new clinical strategies to use BMP2.
So, like Professor Stromer said, is it a case of maybe dipping our implants in BMP?
That would be a nice way to use it if it would be a FDA or whatever regulatory compliance organization would allow it. Yeah. Putting BMP on an implant would create a biological device, and now we'll all be buying $3,000 implants, which means no one will use them. I will say that there are occasions where BMP is the only alternative we have. It's a nice tool to have in our toolbox. It remains a challenge to see how it should and can be used. It's not a bone graft material like we use bone. I'll just leave it at that.
I want to share with you a comment, possibly a very profound comment. This is Innovation Talks, and it's about the future. We were all together before we came in here, just sort of running through this program. And Frauke, you made really a very profound comment when you asked the group whether we really wanted our implants to last a lifetime. I mean, that's what we dream of, but there is an underlying message there, I think. So why don't you expand on that?
Well, yes, we were talking about, about what we would think of would be a nice innovation and what would be useful to have. And since I'm seeing a lot of patients who are dependent on care, who are elderly, and who cannot take care of their implants anymore, and also who lose their abutment teeth and who finally arrive at the state of a removable denture. And for me, a really nice innovation would be that an implant would not last for life, and that it sort of ages with us. And since it doesn't age, or at least we could remove it controlled, like with them. We were talking about the red dip solution. You just put it on and the implant disappears, and you can have a new one in a better place. So,
well, of course, that's the problem, isn't it? Inanimate objects don't age in quite the same way, but they do age mechanically, of course, which brings me neatly back to the question I raised and the comments made by Lyndon. The fact of the matter is that mechanical components fatigue. The question is, it's one thing placing an implant into a 70-year-old, it probably will last a lifetime. Place it into a 25-year-old, and we just don't know. Dr. Han, I'm curious to know, what is the average age of the patient you're treating in your short implant study?
The average age, the mean age is about, if I remember clearly, is 45 years old.
45. So I don't know what the life expectancy is in China, but in Europe it's around 80.
Yeah, China is about 73.
73. So you're looking at a life expectancy for the implant of 30 years.
Yes.
Do you have concerns from a mechanical, not from a biological perspective, but from a mechanical perspective about whether these components are going to survive that long?
Yes, I think
You think
so.
they, yeah. And what happens if they don't, Marco?
If the component don't?
Yeah. I mean, of course, we're using components that we totally trust, but not everyone works with the systems we work with. But what happens if they don't? I mean, it is a real problem out there today. We all see it. Abutments fracture, screws fracture. So what happens?
Well, I think that one of the reasons why we sometimes see fracture is related to the poor quality of the components and the clones and all these kind of things that we see everywhere, just to decrease the cost. This is one issue. And the second is that I see more frequently are very poor design or ill-fitting restoration. These are basically the two more important reasons why we do see fractures. Fatigue and other issues, they happen indeed in the long term, but I see they are more related to the prosthesis than to the components. If the prosthesis is, if the component is a good quality, I haven't seen those many complications.
Okay, but there are other things, aren't there? There's there's differential growth. Implants don't move in the growing jaw. Recently, earlier this year at the EAO, Daftari gave a presentation showing case after case after case after case of young patient that he'd treated 20, 30 years ago already, and now the implants are entirely in the wrong position. We have PeriImplantitis. Today is not the day to debate how prevalent that disease really is or not, but it is in existence, it is a problem, it is a maintenance issue. Should implants be forever, or should we be taking the orthopedic approach? I know it's a well-worn cliche, but having a hip implant or a knee implant, my God, is far more invasive than having a dental implant. But they think nothing of telling a patient that this is not going to last forever, that this will need revision or replacement in 10, 15 years. And I just wonder, because Frauke mentioned it, and it just hit a bell in my head, I wonder whether that is an argument, Fouad, for the short implant, rather than the massive graft and the long implants.
If you saw the indication when you are inserting short implants. You are inserting short implant because there is no possibility to put a longer implant. So you have already a reduced bone situation. Now, we have sometimes PeriImplantitis. I don't know how with the other colleague, perhaps they don't have PeriImplantitis. But if you have a 6 millimeters implant, and this implant will lose after 5, 6, 7 years, 3, 4 millimeters bone, which in many cases could look like a physiological bone loss. So you have only 2 millimeters are stay in the bone. And we saw then the bone loss is going to be quicker. And it's not so easy. You say, okay, I remove it, I put one more time. Because when you are going to lose it, you are going to lose much more bone. So at the beginning, you had a very limited bone, and after you lose the implant, you are going to increase the bone loss. So how is going to continue the treatment? If you have a long implant and you lose the 3, 4, 5, 6 millimeters bone, you still have, it is 15, you still have 9 millimeters. You can control the PeriImplantitis, that's what we are doing. You remove the root surface, you have to make better maintenance, and you see my patient today, after 20 years, after 30 years, they still have the implant inside, which I treated them 30 years ago. Of course, they lost bone, yes, but the restoration is still inside.
Most probably. I think that the issue is not to place short or too long implant. You know, I probably think that we need something medium as an implant. The problem is probably we don't need a very long implant. But the issue of that raised Dr. Müller is very interesting. Should the implant be removable? Most probably, we should simply change the kind of restoration. I mean, at a certain period of their life, we want to have fixed. Then, just when we turn out to be whatever age is, we just change the restoration, change the abutment, and make it removable. Why should we really remove the implant, lady?
Well, I'm not, just to be clear, I'm not promoting disease, and I'm not promoting wear and mechanical failure to get rid of implants. That's quite obvious. But I think to adapt to the aging process, which the rest of the body undergoes, that would be something adequate. And therefore, I think it would be a nice idea.
If I might add a comment here, I think the general theme of this discussion is the cognitive dissonance of what we think we're doing and what happens in reality. When patients receive a dental implant, it is an acute therapy for an immediate problem. But the reality is what we're doing is we are invoking a chronic condition for these patients. They now own a biological device. But we don't go to meetings and learn to deal with chronic realities of an indwelling biological device. We come to meetings, we learn how to acutely address a problem by doing something to our patient, whether it is a bone graft, or the use of a short implant, or the use of an angled implant, or the use of whatever. And Marco raises the issue of perhaps as our patients age, things need to change. And Frauke did the same thing. And perhaps our sentiment about what we're doing needs to change completely, that when we see a patient and talk to them about a dental implant, our discussion needs to be one about taking care of them for a lifetime. And that lifetime of care will involve the possible replacement of an implant, the likely replacement of the prosthesis. And to the point which I spoke regarding implant design, I think it's refreshing to see that, and disappointing at the same time, that only a few implant manufacturers have actually acknowledged that components break and fracture and have done something about it by changing either the material they've made their implant from or completely redesigning a system so that we can place a robust device in someone's mouth so that perhaps we can go a little bit further.
But you made a very interesting comment in passing during your presentation where, of course, in order to provide the robustness of the implant abutment pillar, you need a wider diameter screw, which requires a wider ridge width. So maybe it's a little bit of both. Maybe we will still need augmentation to provide a wider ridge, if not a higher ridge, so that we can put in short, wide implants, because I do have a concern for using narrower, short implants.
And we teach a very similar philosophy to what you're suggesting, is that narrow implants are designed not for buccal lingual discrepancies or insufficiencies, but for mesiodistal discrepancies, where you just run out of space between two teeth. Grafting should be invoked. And we teach that short implants are not a reason to cut down a narrow ridge and use a short implant, that horizontal augmentation is a reasonable procedure. But perhaps in an argumentative way, I'll suggest that the data on vertical bone grafting that does exist suggests that we have not yet completely defined the protocol or protocols by which every one of us can achieve vertical augmentation. In the face of that compelling evidence, I think short implants represent a remarkable alternative to vertical augmentation. And to your point, I think there's nothing wrong with a horizontal augmentation to achieve the proper platform for the proper restoration.
Well, I certainly think it's probably within the skill set of a wider group of clinicians than vertical augmentation,
Absolutely.
which requires a much higher skill set. Dr. Han, Lyndon just commented that one of the keys is long-term maintenance of these patients. But in our interview, you mentioned that very often you aren't offered the opportunity for long-term maintenance with Chinese patients.
Yes.
Do you see that as becoming a problem for your implant patients?
Not by now, but I would emphasize that considering the high prevalence of periodontitis in Chinese population, relatively poor oral hygiene and the low follow-up rate compared to Western patients, the proper professional periodontal treatment before implantation, strictly follow-up and mandatory suppurative periodontal treatment are the keys to reduce the risk of this short implant treatment approach in the long term.
So forgive me being a little bit provocative, and I hope I don't insult you, but is the Chinese public ready for dental implants then?
Yeah, it's a difficult question. But I mean, we still need to educate our patients and our dentists. Because some dentists and some patients don't pay attention to the periodontal health. So, and some patients do the implant treatment without doing any periodontal treatment. Is risky.
Well, if it's any comfort, I can promise you it's exactly the same in Europe, and it's exactly the same in America. And so I was only being provocative, but it sends out a perfect message that, you've got to deal with the basics before you deal with the more advanced or complex issues. And ladies and gentlemen, I think what's really coming out of this is that, perhaps as we said at the beginning, there isn't a single treatment as a panacea for every patient. Fouad showed us very specific, three-dimensionally complex cases that simply couldn't be treated by a short dental implant. By contrast, Marco, you showed a series of really quite phenomenal cases that requires a particular technical skill set. I mean, some of that immediate bridge work you show isn't within the capability of a lot of clinicians because maybe they don't have the technicians on hand like I know you do. So I think one has to take each of the aspects that have been presented today and put them into the perspective of the patient as he or she presents with the defect or the problem that he or she presents with at that time. Is that a fair summation? But there is a place for short implants, undoubtedly. There is still a place for Fouad to do his autogenous bone grafting, but perhaps the parting question, because I loved it so much, should be, should we really be planning to place an implant in a 25-year-old and try and promise a lifetime from it? Perhaps that's the wrong thing to ask of it.